and welcome back to the Journal of Oncology Practice podcast from ASCO. This is Dr. Bob Miller, consultant editor at the JOP. ASCO has done a census of oncology practices in the United States, and a preliminary report was just published in the January Journal of Oncology Practice. Joining me this morning to break down such questions as to why this was necessary and what was learned from the process is one of the authors of the paper, Dr. Anupama Kurup. Dr. Kurup is a medical oncologist at the Providence Cancer Center in Portland, Oregon. She is past president of the Oregon Society of Medical Oncology. She has been involved in the ASCO Clinical Practice Committee since 2010 and is currently the CPC chair-elect. And her life is about to get very busy, I think. Dr. Kurup, welcome, and thanks for taking your Sunday morning to join me.
Oh, thank you. Thank you very much. Thank you for your interest.
So let me ask you about your paper. I think many people might have been surprised to learn that such basic demographic information about oncology practices in the U.S., things like size or makeup, affiliations, and so forth, isn't already known. Why do you think it's been so complicated to gather this information?
Actually, it was a surprise to me as a practicing oncologist. I just assumed that with my various memberships that somehow there would be some kind of master file in the universe with all of my information. But I think part of this is that many of the organizations have perhaps the physician names, perhaps even an address, but not necessarily is that information very clear. Some physicians work at multiple locations. Certainly, whether they're working in a practice that is standalone or affiliated, sometimes it's not very clear. Also, there's so many shifts going on, and I think that to keep up with that, these lists of physicians and oncologists is not necessarily current, and gathering that information did turn out to be quite difficult, although we tried to use many sources.
What was ASCO's interest, and what were their goals in performing this census?
Well, I mean, one of the main goals of ASCO is to meet the needs of its members and the oncology practice community in general. So really, in order to figure out ways in which to help and assist in oncologists providing high-quality care for their patients, we really need to understand how the physicians are doing, what environment they're working in. And we know that there's a lot of shifts in healthcare delivery, and there are also concerns about physician shortage. And so ASCO really wanted to strive to get some basic information about the practices in which oncologists work in, and whether they can use that information to tailor some of their educational products, practice support, and advocacy efforts depends on getting that information down to more detail. And so originally the plan for the census effort was to collect systematic demographic data on all the U.S. oncologist practices and to find out how they're adapting to any administrative or financial pressures and opportunities, and to sort of develop a tool that we could then use to monitor this in an ongoing fashion so we can better serve our members and our oncology practice community in general.
So it sounds like this was sort of part of ASCO's larger interest in the oncology workforce, because we've been hearing about that for a few years now.
Right. And ASCO is really trying their best to provide some amount of advocacy for the oncologist community in general with all of the shifts that are going on with healthcare delivery. And I think it's important for us to all understand, well, where are physicians working? What forces do they feel? What pressures do they feel? And is that impacting how they are delivering that care?
So tell us a little bit about how you went about doing the census. In your paper, you talk about using several different databases like the AMA master file. I think most of us have heard of that, although I be honest, I'm not exactly sure where that data comes from. But can you describe a little bit about the data sources that you used and some of the final statistics that were in the paper?
Sure. In order to do this, first of all, ASCO contracted a partner organization, which was the Center for Health Workforce Studies at the School of Public Health at SUNY Albany. And with that contractor and a lot of ASCO staff support and physician volunteer support, we sought to figure out what databases we wished to use. And it seemed that the most comprehensive ones we could use included the the CMMS National Provider Identifier Registry. That has some address information, some ID information on healthcare providers, especially in relationship to them receiving Medicare reimbursement. The AMA master file actually is a master file supposed to cover some address and limited demographic and practice information of all the United States physicians. And then, of course, we also use the ASCO membership database, which has, again, some address and limited information on physicians. And we also used our ASCO state affiliates to try to get more granular with information on name and addresses.
I want to call the listeners' attention to, this is on page 11 of the paper. There's figure 1 has a graphic of all of these. Can you talk a little bit about, I guess there was a process of, they started with over 65,000 records and ended up with closer to 30,000 records. How did they get from one to the other?
Right. So with all of this information from all of these databases, there did need to be some process of cleaning up of the data and deduplication work. From all of those, we got about 66,000 physician records with a potential for like 20,000 practice addresses, which, of course, we knew that was overshot. We know that there's probably somewhere around 13 to 15,000 oncologists in the United States. So from that, we really, with the use of our contractor, used some techniques to figure out which physician records were duplicated in unique practice addresses. We did get a final inventory of practices, which was more than 4,000 practice addresses. With each of those practices would have then been close to 30,000 physician records. And we knew that was too many physician records themselves, but our point was to actually get as many of these census survey tools out to as many practice addresses as we could so that we could grab anybody that we may perhaps been missing.
I see.
So our objective was to get a comprehensive list, but not to get too many duplicates in terms of the physicians. But we sent out the census to more than 4,000 practice addresses, and we actually got back about 632 practice respondents.
I see. So that was your final data set, or at least as of this data collection. Okay.
Right, and that led to getting information about 4,500 physicians individually.
What were some of the questions that were on the survey instrument, and how was the survey actually carried out?
So the survey was launched in late 2012, and what we were first of all going with was questions we were interested in. We wanted to know information about practice ownership and relationships, what services were provided, whether there was electronic health record used. We also wished to figure out whether there were changes in the past 12 months prior to the survey that related to ownership or affiliation, staffing changes, salary changes, or the volume or mix of patients these practices were seeing. Mm-hmm. And then we also wished to know what the likelihood there was of changes in the next 12 months. So some of the questions included, does your practice have a relationship with a company that provides professional management services? Does your practice use an electronic health or medical record? The FTE number of physicians and active non-physician clinical staff like nurse practitioners and PAs. And then specifically questions about whether in the past 12 months they had experienced a merger, or over the next 12 months were they likely to change their level of affiliation or relationship with others. We even asked questions like, what was their plans for changing their level of participation with clinical trials?
You mentioned there were some types of practices that seem somewhat reluctant to participate. Can you explain that a little bit?
Well, it seemed through this process that particularly several large integrated practice networks seemed to be reluctant to actually fill out the survey and participate. Some practices that were within professional management service networks seemed to be reluctant to fill out the survey, even though we knew they existed.
What was the rationale? I mean, do you have any insight into what?
We, of course, seeing as how they did not respond to the survey, we can only guess. Certainly, we felt that perhaps there were some worries about sharing proprietary and competitive business information. We're asking them about what changes did they have in the past 12 months, and what do they anticipate doing in the next 12 months. So perhaps that had something to do with it. But also, I think that some of this goes to some of the limitation of the study. It was, although we pilot tested the questions, and we realized that the survey was meant to go to the practice managers so that they could fill out this information on a secure online web application in the ASCO website. But it required some information, and it was a bit labor-intensive because we had a lot of questions to ask them. And it required either the physician or practice manager, whoever filled out the survey, to sometimes reach out to other folks in their institution to be able to answer those questions. And perhaps that was part of the barrier as well. That
may have been a reason for sort of self-selection. I mean, I'm guessing there's probably going to be some practices that looked at the questions and maybe gave up after a little while.
And I will tell you that as part of this, we knew that this might be difficult. We did offer some incentives for the first 300 participants or so, small incentives like a gift card to Amazon.com. We also did a lot of legwork. The ASCO staff and physician volunteers reached out among their state affiliates and practices they knew. And so there was some amount of information that we were able to get. In fact, this additional work by the ASCO volunteers led to discovery of 196 practices subsequent to the launch.
That's good. I know I received the questionnaire at Johns Hopkins, and I wasn't sure exactly who's supposed to fill it out. And so I know we did fill it out ultimately. One of our administrators did, but I could see that it was going to be a little bit of work to do it. A few months ago for this podcast, we talked to the group from Oncology Metrics that does the annual National Practice Benchmark Report, Tom Barr and Elaine Toll, and they sort of said the same thing, that they realized over the years, having done surveys for 7 or 8 years now, that there's an attrition rate, that as the survey gets more complex, it gets the data that you think you're going to collect are more interesting, but the participation rate goes down. So
we hope that with ASCO, with the amount of work we do, I know that many oncologists appreciate the work that ASCO does, and they do feel like ASCO is doing more broad, general work for everybody. And we hope that with this article coming out in the JOP, that physicians and their practices might say, oh, I didn't fill out that survey, I should. And we also hope to really kind of go back and get more feedback and work on that, work on our tool, make it a little bit less cumbersome. We really do wish to keep the people that we got in the survey so that we can follow their trends, and really hope that more people will participate.
Mm-hmm. Great. Well, let's talk about the findings. Can you tell us a little bit about what you found particularly interesting, again, recognizing these are preliminary results?
Yeah, I think there were several interesting things. Now, I always have to say, remember that we only got a portion of the respondents answering. So whatever information we get, whatever percentages we think are interesting may not be completely accurate, and we have to remember that. It seemed to me some of the interesting things included that in terms of practice affiliations in the respondents, there were 57% that reported an affiliation with a community hospital, and 28% with an academic center, and 28% with another type of medical center. I thought those affiliation numbers were very interesting. Also, in terms of staffing, it seemed that smaller practices were more likely to have reported that they were laying off physicians or oncology-certified nurses coming up in the next 12 months. And actually, larger practices seemed more likely to hire more providers. And also, it seemed that metropolitan locations are more likely to have practices that have experienced mergers with other practices, with larger practices showing a greater likelihood of purchasing other practices. Mm-hmm. Mm-hmm. And this, I think, seems to fit what we all see around us. And so I think that seems to be interesting information.
There was one statistic I wanted to ask you about. If I'm reading this correctly, I think it was 71% of practices offered hem-onc services, but chemotherapy was offered at only 43.8%, which doesn't quite make sense. Does that say something's changing about the delivery of ambulatory chemo these days, or am I reading into that too much?
Yeah, we thought it was a bit problematic as well. I think that we don't have accurate information. It seems problematic that more than half of the practices aren't providing chemotherapy services at their practice site. And so I think we need to delve more into that information further.
I think you also asked some questions. Well, you said you asked some questions about the future and the coming trends, hirings and so forth. What type of findings did you have there?
I think the biggest point was that it seemed that we're seeing that smaller practices, at least the ones that responded to the survey, seem to be struggling a little bit more to stay by themselves, that they are more likely to close their practices in the next 12 months and being purchased by other larger practices in general.
Were there any regional differences of interest?
In terms of the question of where is there more hiring of oncologists going, it seemed that practices in North Central and the West regions seem to be more likely to plan to hire oncologists the next 12 months. It is notable that in terms of our respondents, that there were more practices from North Central area of the U.S. that actually responded to our survey, and while the West and Northeast were least likely to respond to our survey. So I'm not sure exactly what that means, but it does still seem that the North Central area is still growing in terms of their practice size, at least.
Are there any other data sets that corroborate that?
I'm not sure. And I think that we definitely do plan to sort of correlate some of this information with other databases. And actually, we hope that if we can get more survey participants, we can tease that information out better.
So I guess that leads me to the next question, which is talk about the next steps. Is this data collection complete, or is this still an ongoing process?
So we now have the tool. We have the Census as a tool, as a web application on the Oncology ASCO website. And we are currently working with some of the feedback we've received regarding the survey tool. And we are hoping to get the survey tool itself a little bit less cumbersome. And we really hope that we can publicize this effort and our goals so that physicians can understand what our true goals with this information is, that we are doing this so that we can serve our physician oncologists and their practices better. And so we are going to push for more publicity on this at the annual meeting, look for more publicity regarding this, and we really hope that more people, even at the annual meeting, will reach out to us and get enrolled so that they can get involved in the census.
Is the data collection open right now, or is it closed?
No, No, it's not open right now.
Okay.
We're still working in improving our survey tool a little bit, but we will be announcing the enrollment soon, and certainly with the annual meeting, we will make a major push for people to participate.
And I think you said this earlier, but the mechanism will be a web-based electronic form. Is that correct?
Yeah,
Okay.
It's a web-based electronic form with a username and a password so that your information can stay private.
Are the data de-identified in the analysis phase?
In the analysis phase, yes, it is. And actually, we kind of, in some ways, have to use both. We have to use the information identified and de-identified so that we're making sure that we're not getting duplicates. For example, you mentioned that your institution has several physicians, and we want to make sure that the collection for the entire institution is as a whole, rather than having maybe perhaps two enthusiastic people filling out the survey from two different clinics.
That'd be a good problem to have in some level. But I can see where that wouldn't help your data analysis very much. So, Dr. Kurup, thank you very much for joining me to talk about this paper.
Thank you very much for inviting me. Thank you for spreading the information about this important oncology census.
And to our listeners, please take a look at the rest of the January JOP for additional interesting papers about the oncology workforce issue, always a topic of interest. I will also take a moment to note that the JOP has recently been accepted for indexing in Medline, which should make work like this paper even more discoverable and accessible in the future. And as always, thanks for downloading our podcasts. Send us your comments to jopeditorsdesk@asco.org or comment online on iTunes. This is Dr. Bob Miller for the Journal of Oncology Practice. Thanks very much for your attention.